say many, many years. Let me just first acknowledge, by the time that most of the people leave the room, the presence in the back of a large group of scientists from Toronto. As you know, since many, many years, actually you don't know, and I would have liked to have more Swiss urologists here. About every month, Toronto knows that there is a Swiss group meeting. And actually this is a large part of the Swiss group, so it's a Swiss group. Yeah, a large group of scientists since many years has been working in Toronto with Laurie, myself, Neil, on very specific projects. And basically, the largest project is a large study about the epigenetics, the genetics and the proteomics of the family of the calligranes. And the only person that couldn't make it is, and that you certainly know, is Eleftheros Diamandis, Papa, or the father of the calligranes. But we have Barty Bapat, epigeneticist, that will speak with Ekaterina, Hilmi Ozelik, top-notch geneticist and pathway modelist, and with Lee. And we also have Laurent Briolet, our biostatistician and computer modeling, and of course Cynthia. So I think really it's a great thing to have them, and it tells you how the collaboration has been over the years. Now, I'm going to talk about tonight about another study that we've been doing, which is an international study. And probably will answer or try to answer some of the questions that have been addressed in the afternoon. Namely, we were interested to understand the prevalence of latent prostate cancer, contemporary, in a prospective manner among Caucasian and Asians. Now, I think we've discussed enough about the risk of overdiagnosis, of overtreatment of latent cancers. We are all aware of the absolutely stunning difference between prostate cancer prevalence, clinical incidence, and risk of mortality. We do know that there are significant geographical differences in prostate cancer incidence and also in mortality. And we know that, for instance, the mortality for prostate cancer in many Asian countries is very low. We also know that actually there are changing dietary habits. Some of the Japanese have become more and more westernized, and there is some hint that there's been recently an increase in prostate cancer incidence and maybe even mortality. So in order to address the question of a Gleason 7, or many of the questions that we've asked ourselves this afternoon, what is the natural history and what is the prevalence of prostate cancer at the end of the day? We know from the historical sacred data that overall, above a certain age, more people have prostate cancer, at least latent, than they don't. Although, if you look at most of the studies, it would be around 35 to 40% above the age of 50. This is a study from Hungary, 38%. This is a study recently published in the GNCI by Dr. Haas on 164 patients. And you see that the prostate cancer, the prevalence was 29%. Now, the problem of these studies is that if I do a study in Toronto, if I'm sure I'm doing a study in the US, you're going to have a huge contamination because nearly everyone above the age of 50 will have a PSA. So you deplete the entire pool. So we decided to try to avoid these biases as much as we can. So we chose a specific Caucasian population with fairly little sun exposure, not too far from Sweden, in Moscow, very high level, high fat diet. So theoretically sharing many similarities, but there's no screening. And the same thing was in Japan, where we know that after many discussions, apart of 1 or 2 places in Japan, there's truly no screening, no established whether opportunistic or not. The originality of the study was that it was prospective, simultaneous on 2 different continents. We had a standardized methodology for obtaining and preserving the prostate glands. We had a centralized meticulous pathological grading and staging, and we had also great power calculation. And I certainly would say that our pathologist, who is Theo Vanderkwast, formerly from the Netherlands, of course, as you know, the pathologist of the European screening trial, is someone with certainly quite a lot of experience. Now, we recruited 320 prostate glands prospectively obtained using the same methodology. We had this in Moscow and in Tokyo from 2008 to 2011. Prostate were removed en bloc with the seminal vesicle within 24 hours. They had to be within 24 hours and immediately injected with buffer-formalin. All prostates were analyzed in toto. Theo, after many discussions with many other pathologists, chose to use a 3 to 4 millimeter cut. We can discuss whether we can go below, but I'm not a pathologist, but he said that even below that, that would be an issue. And we, again, analyzed the data. Most of the results, and I really would give the credit to Cynthia Cook, my collaborator, for having really done an absolutely fantastic job for actually gathering this, and Gina Lockwood for analyzing them. This is the age distribution. Now, what you're going to see is that very few Russians are above the age of 80. Well, actually, you say, why? The study's perspective is not that we decided to take 20 people from that age, 30 people. We just said you day 1 to day 4. If you look at the life expectancy rate of a Russian man in 2012, unfortunately, 64 years. A Japanese man, 84 years. So it was just logical that if you start from day 1 to day 2, and you accrue everyone, you're going to have less of these people. Adjust the distribution. You rapidly see as well that overall the prevalence of latent prostate cancer is the same, exactly the same, in Caucasian and in Asian, although, of course, the age distribution is not the same. Now, if you look at the characteristics, age, 68 years for Asian, 62 years for Caucasian, certainly different. Prostate weight, as expected, 31 grams for Asians, smaller than the Caucasian, 40 grams, as expected. And as we said, 35 versus 37% overall. Now, when you go to the Gleason score, 51% of the cancers among Asians were Gleason 7 or above. 51%. Now, we were so stunned that we went back to Theo. Theo, did you drink something, or what's going on? He reviewed every single, even some, and 51% were Gleason 7 or above. Now, the question would be 4 plus 3 or 3 plus 4. Actually, most of them 3 plus 4. But if you look even at the distribution of Gleason 8 and 9, most of the time people say you don't die with a Gleason 8 and 9. No, actually, we found some who actually died with small amounts, but still reasonable and to take into account. 23% of the Caucasian had 7 to 10, which is certainly not completely insignificant. And even controlling for age and prostate volume, Asian men had more Gleason 7 to 10 than Caucasian. So we say the prevalence is the same, the clinical incidence is way less, and they die way less, although they have more aggressive disease than Caucasians. Where's the problem? And I agree that there's still an age distribution. If you look at tumor volume, then, well, 22% of Asian and 20% of Caucasian has still a tumor volume which would be even over 0.5, and with some of the volumes going to up to 2.5 cc. And if you look at whatever, and Laurie and many people have discussed the STAMI and the Epstein criteria, actually, of course, 50% of our Asians would be deemed clinically significant, and 30% of the Caucasian would have a significant. And even worse, and that's exactly the same as HAS, 11% had PT-free disease. What was interesting, though, was the distribution. Most of the tumors were unifocal, 70%. Whereas if you look at most of the data from radical prostatectomies, most are multifocal. So It would remain to be seen whether unifocality versus multifocality is something which truly makes the difference. I don't know. I have absolutely no clue and no possibility to answer that question. So what is the conclusion? My personal conclusion is that I've been studying prostate cancer for the last 20 years. And the more I get gray hair, the less I understand anything about this disease. Truly, I really don't understand anything. Prostate cancer is found in a similar high proportion, but a different age distribution of Russian Caucasians and Japanese Asian men. A startling and unexpected 50% of cancer are Gleason 7 or above in Japanese, and nearly 25% in Russian men. These data are very much in line with recent data from Detroit, and they were in populations where there's absolutely no screening. So that at the latent microscopic stage, Caucasian and Asian men have the same prostate cancer prevalence, but the incidence of clinical disease and mortality differs sharply. At least 1/3 of the tumors which are found on autopsy would be considered as clinically significant. And I'm sure that if they had presented before they died to Marcus, the prostate would have been removed. Joke. I think that these kind of observations raise questions about previous assumptions related to prostate cancer in Asian men, for sure, and really question what is the meaning of significant versus insignificant prostate cancer, and what is the real natural history of this disease. And I would certainly say that we've seen so many recent papers about genetic markers, protein markers, in people with and without prostate cancer. But we have to accept that certainly for genetic markers, at least 30 to 40% of any control group would be heavily contaminated, probably with prostate cancer. Thank you very much. Acknowledgement, of course, to our colleagues from Moscow and from Japan, Shin Egawa and Dimitri Pushkar, and the pathologist. Thanks so much.
Thank you, Alex, for this very interesting paper. So you're questioning with this how the concept of the tumor, of the significance of the cancer. So do you think that there are differences, genetic profile that, let's say, the behavior of the cancer in Japan are different because there is no metastasizing or no progress? So these cancers are there, but they don't progress? What do you think?
Just simple, pure logics. If you find the same prevalence in two populations, it just means that I think the triggering event up to when they get the cancer is the same. Now, if the clinical incidence is dramatically different, it could be just the way medicine is practiced. If you have PSA screening all over the place, of course you're going to have more clinically detected. But what strikes me is that the mortality, and I was asking Shin and the Japanese people, the mortality from prostate cancer is lower. I don't know whether you guys have other data, but it is lower than among Caucasians. So I really think that the problem we have is not that much getting to the cancer, even getting sometimes to the Gleason 7, but what happens afterwards. What are the other triggering diet, genetic, epigenetic factors which actually promote and will kill the patient? I think, personally, we should focus much, much more on these markers and understanding the different type of cancer than deciding to treat every single person all over the place, removing as nicely hopefully saving, as we've seen, 0.3% of the population. I think, personally, it makes no sense.
Alexandre, maybe I missed this completely, but there was a difference in age distribution, and is this not just an age effect that the older the men are, the higher is the grade? Yes,
however, when we asked Gina to calculate and to do kind of fancy statistics to control for age, control for every single parameter, still, and using two different methods, still it showed that irrespective of age, there were more Gleason 7. So I think it's a fair point, but I think it's as much as we can answer.
So we should today reduce our use of high percentage alcohol?
Sorry?
So we should reduce tonight the use of high percentage alcohol.
Well, I think it's a fair point, but I think it's a fair point because some people said, you know, if you drink quite a lot of alcohol, and for sure that has been some features in Russia, you have hypotestosteronemia, gynecomastia, and you may have a lower rate of prostate cancer. Now, this being said, the rate that we found was exactly the same as in the Haas, slightly more, the same as in soccer, and the meta-analysis didn't really show differences, so I don't think that it played a major impact.
As calculation, may I ask you, the median age between Japanese and Russian are different. Can you make any comment about the life expectancy they have at this age? Is this the same or is it different? You make this prevalence screening, you see, okay, they have the same Gleason 7 to 10. The life expectancy in both cohorts is the same further on or not?
I really don't know. So. I know the data for Canada. I know that someone who's 17 in Canada will live up to 84. I know that someone who is 80 in Canada will live up to 91. I have absolutely no data. I think the billion-dollar question is, let's say that we find tomorrow a cure and that everybody in this room will live up to 130 years. Will everybody in this room die from prostate cancer? At the end of the day, it's one of the... Is it just a matter of longevity? I personally really don't think so. I think it's something different.
Thank you, Alex, very much. Thank you for this talk. And now I'd like to introduce John.